further ado, Dr. Ann Bynum.
Good evening, everybody from South Carolina. We just had a huge storm. I'm so glad it passed before this started because we got these notifications about power outages and all these things. And I thought, dear Lord in heaven, please don't let this be the case tonight when I'm going to be giving this webinar. Before I start, I just want to say that the three of us log on here and we sort of chatted out a little bit to make sure that we're all on the same page before we start these every single time. And I just want to say just how proud I am of just New Smile and Dental High Tech as a company, because when I started helping promote these amazing tools, it was just getting started and not a lot of people knew about it. And I just feel like it's all of you on here who have talked to another pediatric dentist who has seen it or used it, and you're the ones that are being the foot soldiers, getting these into the hands of everybody else. And it's just, I don't know, I love this product, but I love to see all of us working together. I just love to see pediatric dentists like all on the same page about something. And I just want to say that I'm just so proud to be involved with this product and where we're going to take it. So, all right, without any further ado, let's see if I can make my slides work here. All right, well, the first thing I like to do when I do these webinars is give you some sort of personal sense of who I am. It's really hard to build relationships when you're not in person. I much prefer lecturing and being on podium in person. I don't get to interact with any of you. I don't get to know what any of your spouses or family members look like, but I want you to at least see behind, what goes on in my life. And so I'm going to just share some of that with you. This is my husband. This is Matt Bynum. He is a general dentist, and we met in dental school at the University of Iowa. We were in the same class. And we practice together. We're in the same building. And that probably the biggest design flaw was not putting up like walls in between us, because it is like, you know what all of our offices sound like. And he's over there trying to sell $70,000, restorative cosmetic cases. And I'm trying to fight a 3-year-old to get a $150 filling done. These are our kids. This is Matthew, Luke, and John, and they are, well, I would say they were all out of the house, but I actually have one looking at me right there. The college kid is home for the summer, and he just got back from golfing. And then these are our 2 dogs. This is Maverick and Goose. So all boys. I'm the only queen. There's no princesses around here. And again, this is just everybody here, kind of an older picture, but just to give you a sense of who we are as a family. So this is Matthew, 25, lives in Florida, works for New Smile. Did you hear that, Jordan? This is your newest employee. Jesus, I work for New Smile. Matthew works for HubSpot. He does CRM work for HubSpot, and he also is a model. He and his girlfriend model. I don't even get all of that, but that's how they pay their bills. And this is his girlfriend. This is them modeling. I've seen him in probably 10 different tuxedos. He's not married, but by the time their wedding comes around, it's going to be so deflating because we've seen them in so many photo shoots like this. It's just kind of, it's another wedding dress. It's another corsage. It's another tuxedo. But so that's Matthew and Maddie. And then this is Luke. This is our middle son. He's 23. Just became a D2, just finished his D1 year at MUSC. So this is his MUSC only has 1 summer off. This is their summer off. So he came home for the weekend, but he had to go back because he's reffing it's like reffing kickball or something, trying to make money to work on those student loans. This is his girlfriend, Faith. She's in nursing school, and she finished nursing school at MUSC, and she's starting her doctorate in August to be a nurse, to have her doctorate of nurse practitioner. So they're living their best life in Charleston. This is John, the one that's in the kitchen right now. He just finished his sophomore year at Clemson. And this is his girlfriend, Sal. She plays rugby at Queens, and they went to France skiing over Christmas break. So this is, y'all, this is so fun. People say like, oh, your kids are so fun at this age and this age and this age. I'm telling you, when you can go out like drinking and carousing with your kids, obviously not when they're 5, 6, and 7. You gotta be older like this. It is the most fun time. So I'm really blessed to have just a really fun family that live close enough that we can get together. This is going to be my other family. This is work for me. This is my rock pile. This is where I go to to make the donuts. And I told you Matt is in with me. So Matt is at the top of the sign, Bynum Aesthetic Dentistry. I'm Holly Tree Pediatric Dentistry. And then I also runs, some of you on here probably know me more from lecturing about tongue tie and airway, but I do that little side hustle as well. So I have a tongue tie and airway center that runs out of my practice, and I work with a CO2 laser, and that is before the electric general anesthesia came out. This was like my jam. It is still my jam, but now helping people learn about the sewing and the quick sleeper, this is definitely my new jam. So here is my work family. This is Dr. Megan Chorowski, and she and I just became partners this week. All the paperwork is signed, the ink is dry, and we just actually finished like a 2-hour call with our accountant to figure out, for all of you who have partners, and you should probably DM me and help me, because we don't know how we're getting paid. We don't know how we're splitting things. We have so much to learn now that we are partners. But this is Megan. She's been with me since 2020. She gets me. She's definitely the second better arm of the practice. And it's because of her and her leadership skills when she first came on that I can do things like this. I can step away from the practice. I can go lecture. I can go, do things like this to help move the needle for pediatric dentistry. And of course, we can't do it by ourselves. We've got this amazing team of ladies behind us, and they're the ones that really help, grow our practice. Speaking of growing the practice, we had a Dr. Maria in August of last year. So this is, this will be the face of Holly Tree when I'm, sucking down the oxygen and rolling around in the wheelchair, telling everybody it's water in my glass when it's vodka probably. So this is the three of us here. This was Dr. Maria's gender reveal. She's already had baby Dean. She had him in February, so he is already here. And then here's our latest adventure. This is Dr. Bassem Nashed, and I'm putting this in here because y'all, he literally just started on Monday. So this picture was taken on Monday, his first day there. And then yesterday we had leadership training. So our whole leadership team met all day at my house. So on the second day of being in our practice, he was literally drinking through a fire hose, learning behind the curtain and how things run, and how we, work really hard to make things better in the practice. And I will say this about these doctors, just so you know, we got the sewing in our hands in November, and Dr. Maria, Dr. Megan, and myself have not used a traditional syringe since. Dr. Bassem started with us on Monday. We were like, dude, just like hang out, just like meet some patients, learn how we do the templates. So we did a couple of recalls. And then, like I told you yesterday, we had leadership training. Well, I come in today I didn't work today. I came in we had a team meeting today, and I came in, I was like, oh, how was your morning? It's like, I love that thing. I just love that thing. He used it on 3 patients today already. His very first day, his very first time. One of our assistants let him practice on her first, and then he did 3 operatives this morning using it. And his wife's also a pediatric dentist at another practice. And so he's going home every night with bragging rights about how awesome the sewing is. So I'm really proud of him. He broke it out today, used it 3 times, because we really, we want to train everybody on this, right? You don't want, if you got a 10 doctor practice, you don't want like, you want consistency, and you want the best for your doctors in your practice. So really proud of him for taking our lead and using the sewing today. All right, so back to what we're going to talk about tonight. I feel like most people who know, the people who are on this call tonight either are thinking about purchasing one of these units, they have recently placed their order for the unit, they have the unit in their hand and they're kind of like, dingling around with it a little bit, or they've been using it and they're like, I want to jump back on because I want to catch a few things that I maybe missed. So it's sort of a little hodgepodge of everybody that's on here. And what I just want to say first, before I even show any slides, is there are 2 devices. There is a sew-in, and there is a, help me, Jordan. I don't want to say the wrong word because I have the other
Sleeper
word.
one.
Sleeper one. I want to say the other one. So we have the sleeper one, and they look different, but they do the exact same thing. But I feel like if you go, if you're like living on iPedo or on any of the things, people mostly talk about the sewing, but there is this other device that does the exact same thing. And we're going to dive in and talk about what the differences are there and why you may choose one over the other. But I do feel that the name of the sewing gets more play in the market and what we see on social media. Jordan shaking his head agreeing with that. So how did this even, why is this here now? Why are we just all getting this and hearing about this? It actually came to the United States. It got FDA approved about March of last year. So we're just at the 1-year mark of even having it in the United States, but it's been around a long time. There's been a lot of research done on it, on electric dental anesthesia. There's more than 10 million intraosseous anesthesia injections delivered around the world every year. It is in 30 plus countries. This device has been trained in over 35 universities, these devices. There's over 10,000 practitioners that are trained with these devices. This is one time where the United States is definitely late to the party, but on the other side of that coin, we have to give such kudos to the higher ups and the risk takers and broad thinkers at New Smile, because they're the ones that went to bat, found this product, and found a way to collaborate with the company that made this, Dental High Tech, to get it into the United States. Getting things FDA approved, that's not what other countries have to go through. So our process is just very tedious, very expensive, and it has been going on for a while. So we're really lucky that we have people with the foresight at New Smile and New Smile Tech to bring something like this to us, because it's been sitting there on the sideline a while. No one's just taken the leap to get it here. Lectures all over. It's talked about at other events. We were in Budapest in February getting some additional training and learning more about Dental High Tech as a company. And when you talk about these devices, people, and you're like, oh my God, we're so excited about it. They're like, duh, we've had it forever. Like, get on board here, Americans. And there's training courses all over the world, like I said. So we are, the caboose here. We're trying to catch up. We're trying to get all of us dentists in the United States trained. Even Canada has this technology. So here, the top tier here, these are the goats. These are the gentlemen who for the past 20, 30 years have been teaching these techniques across the globe. And now they're stepping foot in the United States and they're helping to teach us. The gentleman in the middle, Dr. Andrew Prinn, that's who came and trained me and my team in South Carolina. Dr. Prinn was also, if you were at Berman and Baby Teeth last year, he spoke on this. He gave a really great lecture on it. That happened to be the lecture that I sat in and had my aha moment about what this could do for patients and practices across the country. So these 5 at the top, they're the top tier. If you go down here, you'll see some other countries represented down there, but you won't see any US flags until now. And this is what you got, people. You got me and Larry. So if you want to learn about, and you got Jordan and Chris, they can help you with the technical stuff. But as far as the hands-on training or the webinars and stuff like this, it is me and Dr. Larry Johnson. Larry's in North Carolina. I'm in South Carolina. And Larry's great. She's so many accolades. I can't even name them all, but she helps teach the Restore courses. She was my boss when I was an examiner for the American Board, which I'm still doing, but she was the president the year that I became a board examiner. So I've been under her watch for many years, and New Smile is very fortunate to have her teaching and training students like all of you tonight. And I encourage you, especially, you'll be totally sick of hearing me yammer on here for the next 45 minutes, but definitely take her classes. She does live courses twice a month, live webinars twice a month, just like I do. Also, you can log on to the New Smile website and all of our stuff is stocked on there. You can click on any of them. They're all a little bit different. But the difference is I'm like for the newgies, like the people who are just getting started, just learning about this for the first time. And Larry takes a little bit deeper dive. She's going to work with you on more difficult cases. She's going to help you with case planning, case management, choosing the correct injection site, how to, really look at your x-rays. She does a really great job of sort of troubleshooting, things that could happen when you're using something like a new piece of technology. So these colors mean nothing, but like I was saying, these are all the countries that these devices are being used in and have been used in for many, many years. And we're just really happy that up in that upper left corner is now the United States, and we're getting to be exposed to this awesome technology. So here's the relationship. Like I said, it's New Smile and Dental High Tech. Dental High Tech is a company out of France. Somebody, I don't even know how all these people got together and speed dated and figured all this out, that this would be a great collaboration and marriage, but I sure am glad that they did. And now New Smile is the only vendor in the United States that can sell these products. So I love this next sequence of slides. And just so you know, all this information I'm giving tonight is delivered to us as KOLs and presenters on behalf of New Smile and Dental High Tech and New Smile Tech, because this is like the standard information that we want you all to have. But the thing I love about New Smile is they let us pepper in our own taste of, making it personal, letting us talk about our families, letting us show some of our own cases. So some of these slides, if you've been on one or two of these webinars, you'll be like, ah, God, I saw that once. Well, I already saw that. Well, yeah, you're going to see it because there's people on here who haven't seen it. But this series of slides is really great. It really gives you a visual of what's going on in the world of dentistry. And this is what an x-ray set looked like 95 years ago. And this is where we've progressed to today, right? Where everything's modern. It's even more modern than this, right? We've got the handheld units and less radiation and more streamlined. And then you can go back and look at the dental chairs. And again, everything is so much easier to clean. It's prettier, it's brighter, it's nicer. We've come a long way that way. And then you look at what the dental syringe looks like, and it looks the exact same. It really hasn't changed much at all. The way it works is the same. I always say you could go to flea markets and find these things, and they may be antiques. They're so old. So let's kind of just take a look back. It's always nice to know where you came from to know where you're going to go. And this is sort of how Dental High Tech came about. In France, there was this city that I cannot name. There was this man who I can hardly name, Alain Villette, and he was a dentist. And he really wanted to find a way to make dentistry painless for his patients, which I think we can all appreciate, because that is one thing that stresses us out, especially if you're giving an injection on a child and you have a parent hovering over you and the child winces or blinks or reaches up. Then all of a sudden, you're hurting their child. 1-star Google review. We're ripping the kid out of the chair and going somewhere else, right? I mean, that's the worst case scenario. But I think we all live to not, hurt children, to make dental visits comfortable. And this is one of the things that like really causes us angst and stress is dealing with the comfort level of our patients. So he was trying to figure out like how can I get the most profound anesthesia the best way possible in the most comfortable way. And he came up with this idea that he had to find a way to get the anesthetic to the nerve, to the apex of the tooth. So he came up with this device called the Injector, and it took many rounds of getting it right, but it did go to market. And around that time, his son became a dentist. So here's his son, Oliver, who helped get this to market, and they were using it in practices, and it was delivering intraosseous anesthesia. And then it started to evolve, and then it became electronic. So it was run with a foot pedal and instead of manually with your hand. So that's how Dental High Tech started. All this took place back in 1997, which for some of us, it's a really long time ago. And for some of you, you weren't even born or around yet. But it was just this tiny little company. And if you can appreciate the cartoons of the building, you'll see how much they grew. So then they came out with the Sleeper One. Again, you can appreciate, it's starting to look like some sort of electronic device that's going to give an injection. By 2005, they designed a proprietary needle called the Effitech needle, and we're going to talk about why it was so special and why it's such a great addition to this device later on. But they did develop this and patent this needle called the Effitech needle in 2005. By 2007, they married it together. You have the special needles and the special device. And now dental high tech's really taken off, right? Look at the size of the building. We're growing as a company. We're scaling. We're selling units. Now we've developed by 2011, the Sleeper One now has a foot pedal. And this foot pedal is starting to look like what you have in your offices or what you're about to have. If you've already purchased your device and it's not there yet, or you're going to get off this call and call Jordan and give him your credit card number and get one. So here comes 2017. We have the Sleeper One 5. Now we just really call it the Sleeper One, but this is what it looks like. So it plugs in, it's an electronic wand looking thing device, and it's got the foot pedal with colors on it. So this is what this is a close up of what the Sleeper One looks like. And what I want you to appreciate on this slide is that blue light. That blue light talks to you. See how it's orange? The person holding it, it's got an orange color to it, but on the back part of the slide, it's blue. So that light tells you a story the whole time. It's either blinking, it's blue, it's a different color, it's not on, it's blinking fat. It tells you all kinds of information. And the nice part about the Sleeper One is that blue light goes all the way around it. It's circumferential. And you'll see that on the sew-in, that is not the case. And again, this is driven by a foot pedal, but you still have to plug it in. And then this is what the sew-in looks like. Sew-in is not an acronym. We cannot figure out what sew-in means, what it stands for. Dr. Bobby Elliott has some pretty funny acronyms for it, but I don't know, it's just called the sew-in. And you can see, you can appreciate on this device that the flat side that has the controls on it right there, the on-off button and the plunger button, right above the plunger button, there's 4 lights. So there's 4 lights that blink and talk to you. But the downside of the sew-in is they don't go all the way around the unit, right? So you either have to be cocking your head to see if those lights are on, or what we do in our practice, most of us, I would say, is we check in with our assistant. Like, hey, is it blinking? Is it blinking too much? Like, tell us what sort of feedback you're getting from the device if you have it positioned in a way that you can't visibly see the feedback that it could be giving to you at that time. Jordan, tell us while this is a good photo right here, what is the weight of this unit?
I don't know the exact
gets
weight
asked.
in grams. It's just slightly heavier than the Sleeper One.
Which we don't know how many pounds.
I don't know the grams of them. I don't know the exact weight. You
Okay.
put me on the
It's not,
spot. I don't know the answer. Ann.
that's all right. That's all right. Well, I knew I didn't know it, but that is one question that seems to come up a lot is, gosh, it looks heavy because it looks robust and it's kind of fat there at the end. And that's just not a complaint. Like, we just don't have. Are you going to bed? Okay, good night. I love you. He's not going to bed, y'all. He's going to play Xbox for like 7 hours. No, can't talk. Okay, I'll come see you when I'm done. Okay.
And if you remind me before the next one, I will waive these and actually get
Okay.
I will try and figure that out. I'll actually try and weigh them and try and figure it out.
All right, sounds good. Sounds good. But from a practitioner standpoint, they are not heavy. I feel like that is a concern when people see it. They think, God, that looks like really heavy. It must be like hollow inside of there. There can't be much to it on the inside of that plastic because it is very light in weight, I feel like. So again, we are changing things in dentistry now. We no longer have to use the traditional syringe in our practice. They're bagged up, they're back in sterilization, they're not even an option anymore. And that'll be the thing. If you don't have the sew-in or the Sleeper One in front of you to use it, your knee-jerk reaction is gonna be for your assistant to hand you just a syringe. So to make yourself successful, we definitely want to make sure we pick the right cases to start and learn with, but we also don't want to have a fallback unit. It's kind of like having cookies in your house when you're trying to be on a diet, right? Just get them out of there so that you're not tempted to pick it out and use it. So these are the things we're going to cover tonight. I'm not going to read this to you, but we are going to go through 8 talking points here tonight. The first one, anesthesia and pain. love these pictures, right? It just looks like we're the most like devilish people on the planet. They were probably like, okay, kid, squint your eyes really tight while I hold this needle and pretend I'm using it on you here. But I will say that is the one thing that, we deal with on a daily basis, even general dentists, right? Like nobody wants to hurt a patient. That's not how you build your practice. You get known for that. People aren't going to be coming back to you. You hurt someone's child, forget it. They're going somewhere else. So, this is just one barrier that we're removing to provide quality care to our patients. So this is just going to talk about, what we all deal with.
Playing jazz.
Playing jazz.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkaren at 9:30.
Fire off.
Fire off.
Open door.
Door open.
Så ska vi sätta en till.
Ja. Open door.
Run voice command.
Open door.
Run voice command.
Open door.
Repeat that.
Open door.
I didn't understand that.
Hurry! Open door.
Play on the floor.
Get on the floor. Open the door.
Error.
Area. We rock. Open door. Fire.
Fire going.
Fire.
It's about how it is when your face is numb and falling off, right? Things can go sideways pretty fast. So problems of traditional anesthesia, obviously fear, right? Patients are scared of the needle, scared of being hurt by us. All the trust isn't built, the discomfort. That's a grown man trying to get out of there, but I think we can all agree that we've had a patient try to run for the door and go to the parking lot in our own practices when they know something scary is coming for them. So, it's uncomfortable, especially when the needle first passes through the gum. It's uncomfortable during the delivery of anesthetic. We never know how effective it's going to be, or we're anticipating that, oh gosh, we're getting deeper, we're getting closer to the pulp. Are they going to jump? Are they going to feel it? Are they going to blink? How are we going to know? And then the other thing with traditional anesthesia is we're dealing with lip biting and, discomfort afterwards, because all that anesthetic is bubbled up into the tissue, and, just flat out pain. So let's give ourselves a chance to do it a different way and do it pain-free. That's going to reduce our stress of the patient. It's going to be immediate, so that's going to reduce the stress in us. And once you've got the techniques down, it's always going to be effective. This is going to reduce our stress. We're not going to have any side effects. Everybody's going to be happy at the end of this cascade right here. And it does take, I say that when it says on here, always effective, it is always effective, but there's going to be a learning curve. We're all going to have a learning curve. I mean, I'm still in a learning curve, trying to get it right and inject in the right spot and the right amount and all those things. So just, be patient and be kind to yourself. So for the patient, again, things we talked about, collateral numbness. This is a big one. This is the phone call we get at 8:30 at night on a Friday, or well, if you work on Friday, but they had a allergic reaction. We had to go to the emergency room, and they ran a whole panel, and now we got a $3,000 emergency room bill, and they're allergic to Novocaine, right? That's what you get told. They're allergic to Novocaine. And so we can prevent all this. We can prevent all this nonsense that they get told in the emergency room. We can prevent parents freaking out when they see their kid an hour later after they've chewed up their lips. But so, having that off the plate, because I guess what I failed to say on here is that with these devices, giving an intraosseous injection, it doesn't numb any of this. Like your skin is not numb, your cheeks are not numb, your lips are not numb. So that's not even the chance to be a complication. And you're not having to give more injections. You're not, I don't know, some people on here are like, I give palatals, I give infraalveolar, I give like 4 or 5 different things around a tooth to kind of like hooey it and make sure that it's super numb. We're literally injecting in one site. We're giving 2 injections, but they're in one site to get profound anesthesia. So things that help the dentist, it's going to get rid of our inefficiency. It's going to help with behavior management because it is a comfortable, kind way to numb our patients. Patients accept it much easier. Again, what a horrible picture. I don't know anybody that gives an injection that way, but is that a Gowgate? I don't even know what that is, but that is, you know, whether that's the position you're in or not, this is how we all hold a syringe. You know, we're all like using our hand like this all the time and giving, you know, how many injections a day? 10 to 12 probably. So we can avoid all of this because it's very, you know, can be very strenuous on the hand. And I think it was Loree who was talking at Bourbon and Baby Teeth that she was having some issues with her hands. And she's a super healthy person. And, you know, she's, and, you know, younger than me and already starting to have problems. So this is, you know, this is helping her overall health by not having to give traditional injections anymore. This is going to reduce the number of appointments that you need to have for a number of reasons. One, you can work right away. It's going to numb your patient immediately. So you're not leaving the room. You can leave the room if you want to leave the room and go drink coffee or check recalls or whatever you want to do. That's up to you. But you now have the option and the opportunity to stay in the room and start treatment right away. And also you're not worried about all this collateral numbness. So you can inject in more than one site and you can get a lot more dentistry done on patients, which is going to definitely help reduce our stress. So the goal here is, this slide is like my takeaway slide for everybody. If you want to have the best learning curve and the best success, you want to make sure that you're using the right amount of anesthetic. You want to, or you want to make sure you're using the appropriate anesthetic. You want to inject the right amount of anesthetic. You want to be gentle and patient when you're delivering the anesthetic. And you want to make sure that you're in the right target spot to deliver the anesthetic. And we're going to kind of break all those down as we go here. So the right spot is the apex. That's what we're aiming for. Malamed says once the tip of the needle passes through the gingiva, every single one of us is giving a blind injection. Nobody can say they never hit a nerve, they never damaged this or that, they never got something in the blood. They never get something in the bloodstream. That's just not true. We're all giving blind injections once we've passed through that mucosal membrane. So we're trying to really be mindful of our anatomy, knowing what our target is and finding the best way to get there. Again, these are the 2 devices. This is a great picture actually to see the difference in the devices as far as those lights show up there. Jeanette, are you good to stay on with me a little bit or do you want to jump in now? You tell me what your night looks like, girl.
Hi, can you hear me?
We can hear you.
Yeah, hello. I just got home from work and just
Okay.
joining you. I'm enjoying your talk. Every time you add in, I think this is my 3rd time listening. Obviously, I missed the earlier part, but I learned a
Obviously,
new.
you're a slow learner or you don't have a life.
No,
But
I think
okay.
I think I glean something new every time. And I can chime in whenever, but I'm enjoying what you're saying.
Okay, well then I'm just going to keep rolling here. And
Okay.
please, Jeanette, feel free to jump in with any comments that you have as well. Everybody, this is Dr. Jeanette McLean. Everybody on this call probably knows her. She is definitely a forward thinker in the field of pediatric, in dentistry in general. And she has the best interests of all of us and all of our patients in mind, helping promote new products as they come to market, teaching us how to use those products. She's very generous in that way. And she is a friend and funny as hell. So she
Thank you.
is now the proud owner of a sew-in, and
Yeah.
I wanted her to if you have been on these before, I try to bring different friends and colleagues of mine on here to share their experiences, because this isn't the Ann show. This is I want you to learn from other people along the way as well.
Yeah. And
All right.
I will chime in then and say, now that you brought it up, the reason I watched it so many times is I am really careful about what I use. I want to make sure there's evidence and that it's like going to do what it says. I don't want to just be out there like hawking whatever shiny new toy comes along. Like I am super skeptical. I will read every article. I am a nerd. And you know, so that's definitely why I've watched all the different webinars and looked into it more, because I heard about it a while back. I think it was Mike, or people would know New Smile Mike, who mentioned, okay, we have this cool new thing. Are you interested? And at the time I was so overwhelmed with other projects, and a lot of people know me because I do mostly minimally invasive dentistry, right? And there's so much I can do without even having to numb someone, that at the time I thought, well, this isn't a priority, you know, whatever. But then you little stinker and our buddy Bobby Elliott were like, this is a game changer. So it really caught my attention. I'm like, well, maybe I need to look into this sooner rather than later. Started watching the webinars, reading into it more. And I am definitely a believer now. But I was hesitant at first, but I'll share more of that later, because I started to think about the cost. Like, I'm going to invest in this device. Do I really need this? Like, if it ain't broke, don't fix it. I became like the skeptics that I try to lecture to, you know, who maybe don't want to try SDF yet or don't want to try glass ionomer. It's funny how I kind of flipped the script on myself. But anyhow, go on. I'm enjoying.
I think that's great, because there's other Jeanettes on this call tonight who haven't pulled the trigger yet, because, you know, they need to do their own research, or they
Yeah.
need some social
As they
proof.
should. Absolutely.
Yeah,
As they should. Take your
absolutely.
time, learn, get comfortable, ask questions. I liked one of Larie's webinars too. It was nice how people chimed in with like just their different questions or the experiences that they were having, because we all learn from each other.
Right. So let's see where we're at. So better way to give anesthesia. We're going to optimize the injection speed. And by doing that, this is going to potentiate the vasoconstrictor effect. So we're not, you know, when you're giving an injection manually, you have no idea what the control of that bolus of anesthetic is. And it really can't potentiate the vasoconstrictors effectively. And this will do this. So it's efficient and it's comfortable. When we're pushing anesthesia, anesthetic with a manual syringe, we have a tendency to cause more discomfort to our patients, because that acid is pouring in at a rate that we cannot control. So this is what the manual delivery would look like. You're trying to put it in. It's kind of like going everywhere, because you're not controlling the speed, right? You're not controlling the pace of the delivery of the anesthetic. And then this is what it looks like when we're using these devices. It's going to keep it at a steady rate. Those vessels can start to constrict before the anesthetic goes all over the place. And again, this is just going to help with, you know, us having discomfort, and we can just concentrate on taking care of the patient, not having to be looking back at our hand. Are we aspirating? Is the plunger in? All that kind of stuff. So you can just, you know, give your primary attention to the patient.
I'll chime in on that part too.
Yeah.
They were showing like about our hands. I suffer from tendonitis. So if I grip something too tightly, my wrists will get really sore or flare up. I can even sometimes get numbness. So initially I was concerned, because when I saw the sewn, I thought, well, gosh, that looks so heavy. So initially I ordered both the sleeper one and the sewn, and then I assumed I would go for the sleeper one. I thought maybe it would be lighter. And then I ended up I was pleasantly surprised at how light the cordless was, and ended up going that route. So I just wanted to share that, just in case there's any other folks out there who suffer from tendonitis or other issues with your hands. It's quite comfortable. And it's actually, I think the pen grip too, like I'm closer to where I'm injecting, and I can actually fulcrum way better than when I was like awkwardly out there, you know, with this big long syringe. It's definitely more comfortable on my hand.
Exactly. And if you don't want to get tendonitis one day, maybe you should, maybe that would be a reason right there to get it. So this is a great little video we're going to show here of just basically the technique. And I'm going to kind of talk through it here. The first injection goes into the papilla. The D is right there on the side of that Epitech needle. It needs to be pointed out towards the buccal. We're just giving enough to numb the papilla. The second injection is going in through the cortical plate, right at the top, where the bone is the easiest to penetrate. And that's our goal, is to pop into that cancellous bone. and then deliver our second injection. And we've got success. We've got anesthetic. We've got blue stuff all around the apex of these teeth where we're going to work. Important slide to know here, when we are giving injections in the maxilla and when we're giving injections in the mandible, it's going to be different. When we're doing it in the maxilla, you can confidently expect 2 teeth forward and 2 teeth back to have profound anesthesia. You may have more numbness as you go further forward or further back, but I wouldn't be confident that it would be profound. It would be paresthesia, not anesthesia, right? And then on the bottom, everything wants to flow to the mesial. So on the mandible, you can anticipate confidently to get profound anesthesia, 1 tooth back and 2 teeth forward. This would just be an example if you were giving the injection right there, what you could expect. And it's a 3-step technique. So the first injection, like that video showed, you're numbing the papilla. The second thing you're going to do is you're taking the needle totally out and you're going back in for a second injection. What we do in our practice is we give that first injection into the mucosa. The assistant rinses the patient's mouth out because it does drip a little bit. And then you go back in for your second injection, which is going to be your intraosseous injection. And the first thing you're going to do is you're going to, like Jeanette was showing, you're sort of like twisting your hand and your fingers to make sure you penetrate the bone. We'll show some footage of that. And then you're going to deliver the anesthetic. Once you're confident that you're in the right location and that you're through bone. So here's just a quick video showing what that drip, that first injection into the mucosa looks like. The machine is literally dripping the anesthetic. So even if you're in the mouth and you haven't pierced the mucosa yet, it's not like tons of anesthetic are flooding into your patient's mouth. Here's an example of doing that. And you just literally lay it against the tissue. The D on the needle needs to be facing out. Dr. Marina is just delivering enough anesthetic. When people are like, well, how much? I don't know how much, just enough that you're going to blanch that papilla right there. And the reason you're doing that is because when you go to give your second injection, you're going to be kind of messing around with it a little bit. You want to make sure that you've got profound, that gingiva is numb right there. So first one, second one, this is what it looks like when you're giving your IO injection, a much faster rate. There's tons of settings on the device where you can start it at this rate. And then once you're in there, it'll ramp up and go even faster. We don't touch things and mess with things in our office. We've got 4 doctors and a zillion assistants. And we live by the, if it ain't broke, don't fix it. So we just leave it on the one setting, but there are lots of cool other settings that you can do with it. So this will be showing that second injection. You can see them twisting it. They're in. Maybe. Excellent. And these are just when the device first came out, this is what people described it as. They say that it's a sensation of piercing through a milk carton or piercing through the outside of an eggshell. This is not the litmus test for you are giving an intraosseous injection. If you do not hear this pop or feel this pop tactily with your hands, that doesn't mean that you're not going to have success. Sometimes you don't feel it. Sometimes that bone is so soft, it just goes in. The needle just goes in. If that happens and you deliver or bury that needle all the way to the hub of the mucosa, you just want to make sure you back up a little bit. You always want to see about a millimeter to 2 of your needle. You don't want to bury it to the hub. You want to have sight of that needle at all times. So here's another example. I won't get into this too much. This is more of a Larry topic, but people ask, well, if that's going to numb the, can I extract those canines right there if I numb right there in that papilla? I don't know. If I'm maybe doing facials on the canines, I would maybe trust this injection. If I'm extracting those canines, I'm probably going to give injections distal to the canines or even mesial to the canines. Just probably something in my head. So again, this is just going to show different regions where we're treating and delivering anesthesia. Again, I don't know if I'm going to trust it's going to go that far. I think this is a video. No, this is just some photos showing the different angulations. And one thing that, like Jeanette was saying, like, you have this pen grip, you have this fulcrum, you're much closer to your patient than you are when you're giving a normal injection. So you'll see in all these pictures, like everyone's hands are super close, our arms are wrapped around our patient. We're kind of used to that anyways, because we don't know when they're going to flake out. But you know, it is a much more intimate setting when you're giving these injections.
It also makes it less intimidating for them, I think. I show them the handpiece, and I liked your line about I'm taking your tooth temperature. I've used that. That definitely works, especially on the preschoolers. And then the older kids who know, who are savvy, I call it a pen. Like I have this cool numbing pen, you know, because it's the 4-letter word shot we know is a trigger word, but I will just straight up show it to them. I'm not having to hide a syringe like we used to have to do, like the Houdini stuff, or try to block their line of vision and hide the syringe, you know, passing it underneath. I hold my hand over the needle aspect and show them the handpiece and say like, oh, look, I have this cool new pen I'm going to use to help numb your teeth. And I have done, I've been doing a lot of lower extractions, especially lately, lots of over retained teeth. And for sure, like you were saying, we used to have to do all these different infiltrations or come from the lingual. And if you have a kid who's all over the place or tasting it and they're freaking out, that's been amazing to just do one, and I can take out teeth on either side of the midline and they're both numb from one injection essentially. So that's been cool.
So again, that's just showing the different angles. Again, you want to come like this high angle on the mandible, and like this when you're in the maxilla, you're trying to visualize that again. You're trying to go through the softest part of that cancellous bone. These are a couple of videos here. And that's just showing, again, the first injection. And I think the second video is going to show popping through that bone, twisting the needle. This is a great slide to say, you know, I talked about the D on the needle. The D only needs to be pointed out when you're giving the mucosal injection. By the time you get to this part and you're giving your IO, you're not worried about the direction of that letter. And so you see how patient this doctor's being. Like, it doesn't always just pop in. So he's got two options. He can keep being patient. Maybe he's going to get it, or he can reposition, or he can take it out and try to reposition. And he stayed with it and he got it. So pretty cool there. Again, let's see. So this is a patient in our practice. This is Dr. Megan delivering anesthesia. And I love that she captured the eye on there, because the kid is the nitrous nose is bothering that kid's eye more than the anesthesia is. And see, like Jeanette said, she's super close. She's got her hands on that pen grip, delivering the anesthesia. Just doing a great job right there. And this is what I was talking about, super intimate. You're very close to the patient. You've got control of the situation. And patients like this, they feel safe. They feel secure when you're up close like this. I won't show this whole video, but one thing I love, this is one of the first videos I saw. The kid is like, she could give a, you know what, her eyes she's not blinking her eyes. She doesn't care. She's got her cute little kitty headband on. This is Dr. Megan using it on a patient. This was just a kid that we've had let them like B2 in the past, right? Like trying to get treatment done and they're crazy. And I said, Megan, just don't even only film like good kids. And she was like, I filmed so-and-so today. And I said, so-and-so is good. She's like, yeah, so-and-so is good. So watch this video. I mean, I can't think of a better way to come to work and have to give injections than to have your patient dancing while you're doing it. So planning out our cases, you got to have bone. To give an IO injection with any device, you have to have some bone, right? So we've got to make sure that we're really assessing our x-rays properly and finding that good bone. And this does not look great right here, right? So we know we've got these two bad teeth. That x-ray is absolutely horrible. So we got to really plan what we're going to do here. We've got bone right here. We can go right here. We can do the restorative case. We can do the restorative work on the permanent molar, and we can pop out those two abscessed primary molars. You're going to look here and say, oh God, there's no bone between those two molars. But maybe pull your pano out, maybe get a different angle or a different view. You do have bone in between there. You do have a good landing site if that's where you choose to deliver it. Again, just showing some other places where you would want to think about. And this is one thing that, like, I'm looking at my x-rays a lot differently. Normally you're just looking at the decay on your x-ray. Now you're definitely looking at your bone level on your x-ray as you're planning out your cases. So here's a few just good options of where you could go to deliver that anesthetic. I think this shows a couple more. Maybe not. Yeah, it's going to show right here. So again, there's a great spot to go. There's a great spot to go. And we've been able to work on permanent and primary teeth all at once. This is just showing it on the radiograph and then where you're actually doing it. This was a 4-year-old girl getting a pulp and a crown on this tooth. And we used articaine, which is Septicaine for us. Septicaine, 4%, 1 to 200,000. We're going to talk about that. And that was the final restoration for her. And then we did some beautiful Zerk crowns on this little kiddo. Went in between E and F. Prepped the teeth immediately. Again, here's some more dentistry being done. I'm going to show this video because this is a mind blower as well. This tooth is like, I would look at this and be like, oh my God, that's a hot tooth. I'm going to have to like give, like Jeanette said, like, you know, a circus of injections here to get this tooth numb. And they numb this hot tooth and go digging on the lingual immediately to get this out. So we're going to assume they looked at a radiograph. They found a good clump of bone to go into. They were confident in their choice of injection sites. Popped in. Oh, hi, I'm going to take this sharp instrument 5 seconds later on your palate.
I was honestly scared to do that initially. I'm like, really? Is it really gonna be okay?
I know.
And my assistants were kind of like mesmerized, you know, like there's just all that sort of disbelief. I guess you just have to try it to
Right.
get over that, but that was definitely a hesitation. Like it's so different than what we're used to.
I call it sorcery. I was telling you weren't on the call earlier, but we had a new doctor start with us on Monday, and he went in to watch Megan do a 9 o'clock treatment, and I saw him right after it. I said, were you in there? How did it go? She picked up a 150 and took out 2 teeth right afterwards. I was freaking out for the kid. I was like, no, that's what we do here now. So this video, this is myself. This is me. And I was in a temporary crown for longer than I should have been. And it fell off one day and it was super sensitive. I kept just like putting it back on and just holding it on with my tongue and eating on the other side because cobblers' kids don't get shoes. I had to get on my husband's schedule. So it was in the middle of a work day. Megan and I were working the day together and Matt had an opening. I said, you got to get this crown on my tooth. And I said, I want Megan to numb me with this. I want to try it. And I am from the neck up. I am petite. And I also had my premolars extracted. So I'm this little like tiny mouth. And I said, Megan, I want you to try this on me. So what I want you to appreciate is, I didn't obviously see the video because I was the patient, but what I want you to appreciate is she's being very, I would not aggressive, but she's having to work really hard to get this needle to penetrate. And I never felt any of it. I never knew this was going on. But I think this is a great video because you're going to see the needle pop in after she makes me bleed. I'm going to bleed here in a minute. And now it's going to pop in. Did y'all see that? That's all it is. And then once that happens, once you know you're in, you put your foot on the pedal, the rheostat, and you go. It's go time. So how we're going to be pain free, we're going to use a special needle that we kind of talked about early on. It's called the Effitech needle, and it's the needle that New Smile Tech sells. We're going to use this electronic anesthetic delivery device that's going to give a nice pace to delivering the anesthetic. And we're going to make sure that we've got our ergonomics and our support points down, our fulcrums, as we're doing this. So this is what a normal needle looks like. If you looked at it under SEM, you can see they're using that as an example to show how it's like tearing that paper or that tissue right there. And that's exactly how a normal needle penetrates your skin or your tissue. Whereas with the Effitech needle, it's not beveled like that. It's beveled like this. It's got a double bevel on it, so it acts more like a scalpel. So it like literally just melts into your skin. Now, this is probably a good time to bring it up. Do you use topical or do you not use topical? You do not have to use topical. You can go straight in, do your thing. Kids are not going to be flinching on you. Once you get your techniques down, you may get a couple flinchers here and there. But in our practice, we have chosen to continue with topical because it's a great little litmus test for how this kid's going to act, right? Are they going to be like, if they're being crazy about a Q-tip in their mouth, that's like your first sign of probably how the rest of the operative visit is going to go. So, again, a choice. If you're like, oh my God, I want to save money on topical and Q-tips, then stop using it. Again, we're just sort of like melting that needle in there, just a little bit of pressure. People are like, I don't know if I'm going too far or not far enough. You just go in a little bit, delivering that. You'll see the tissue start to blanch as the anesthetic gets delivered, and you'll figure it out pretty quick. If everybody on this call could learn how to give an inferior alveolar injection while we were 23 years old in dental school, I'm pretty sure we can all handle this technique. Again, this is what
it does just slide in there. I think a nice analogy would be like the really expensive sushi knives, the ones that are so sharp, it just fillets the soft fish so well. Whereas versus like our dull, crappy knives that you're trying to cut a tomato and you're just crushing it and ripping it. This is like a fine sushi knife.
Right. That's awesome. So again, this is giving like a manual injection. You cannot control, the bolus of anesthetic at all. You think you can. People are like, I don't need that device. I give a great injection. Then you keep giving your low grade injection, and let me know how many calls you get from the ER with a chewed up face, right? Again, so we're controlling the pace with these electronic anesthesia devices. Getting our support systems down is super huge. I would encourage everybody, this is probably a good time to say it. Once you get your device, do the training videos. Don't be the typical man that throws the directions away and says you can figure it out. You're not going to figure it out. You're going to be bothering Chris. You're going to be bothering Jordan. You're going to be bothering people if you don't watch these videos. These videos are amazing. Like, there is so much great information in there that's going to help you, shorten up your learning curve and give better injections right out the gate. And then I think Jordan told me that once you do finish the videos, this may be a new thing, but once you've shown that you've completed the training videos, they're going to send you 2 more boxes of these Effitech needles. So if for no other reason you want to get some free goods, watch these videos, but it's definitely going to shorten your learning curve if you do. So this ain't what we're doing anymore. We've got a nice, we've got our purchase points, we've got fulcrums, we've got our patient stable and safe. So when we're planning our cases, it's going to depend on how close we are to the tooth that we're treating. That's going to decide how much anesthetic we need to give and also what we need to do, right? If we're doing like a little small occlusal on a 4-year-old who has very porous bone, we probably don't need as much. If we're pushing the limit on a 12-year-old that plays football at school and is a linebacker, and we're going to be working on a hypoplastic molar on that child, perhaps, we maybe want to increase the amount of anesthetic that we're giving. You would treatment plan these things just like you would treatment plan if you were giving a regular injection, how much you need to use, where you're going to give it. And then the other thing that we're going to talk about is the vasoconstriction part of it, because most of us, I would imagine, are used to using lidocaine. That's what we had in school. That's what we were trained on. And this is different. We want to use septicane with this device because when you're giving an IO injection, septicane has a much better molecular structure that's going to penetrate that bone better than lidocaine will. So we got two options. We've got 1 to 100,000 and we've got 1 to 200,000. Well, and why would you use one over the other? Well, we're going to use the 1 to 200,000 when most of the time, I would tell you for us, it's all of the time. I'm just not into like switching things out. So this is going to get you about 30 to 45 minutes of working time, whereas 1 to 100,000 is going to get you a little bit longer working time. I'd much prefer to have to go back in and give another injection and just everything's 1 to 200,000. I never have to question, did a 1 to 100,000 carpule get loaded in there by the assistant? I don't want anything else in there but the 1 to 200.
I've
And then
just
the
been
other-
keeping the box of 1 to 200 in
Right
my
there.
office because I'm a control freak. Because we routinely were using the 1 to 100 septicane for infiltrations, but
Right.
for interosseous, I switched to the 1 to 200, so
200s.
lower concentration of the epi.
Right. So again, and you have the options to use either one. Again, like I said, and we don't, in our practice, the longest operative appointment is 30 minutes. So we just feel confident that we're going to be able to get done what we need to get done in that window of time. This just talks about, you're going to, I mean, if there's any questions in here that have been dropped in the box, so you can't be using septicane on kids under age 4. I'm not going to read this to you, but even Malamed says that is the literature on this is just not solid at all. The main study that was done is not solid at all. We're not giving enough anesthetic to anybody to be causing any of these problems.
Yeah. Septicane is all I've used for like over 20 years, including blocks on children.
Yeah.
It's like an unnecessary concern.
Yes, like a myth. So getting it integrated into your practice, again, you've got the sleeper one as an option or the sewn as an option. I'll tell you one of my other reasons for me not personally wanting the sleeper one is, one, I don't like cords on anything. There's cords everywhere with the computers and the this and the that and all the things. Everything has to charge and have a cord on it. And my other thought process was, if you're dragging that cord across the patient to give the injection and the patient flips out or what, they flip out sometimes, right? You don't know what they're going to do. And if they grab that cord, I just thought, I do not want to be dealing with a patient having any control of what I'm doing. So for me, again, this was the choice that I made. So we're just going to wrap up here with some final thoughts. There is a learning curve. So I would encourage everybody to start with primary teeth on a very well-behaved child. Don't, set yourself up for success. Get your confidence built up before you're digging into these, cases that are behavior cases or, older kids. Start with the primary dentition.
A sedated patient is a great first case as well.
Yes, it is. Doctor, yes. We have IV sedations on next Tuesday, and we're going to let Dr. Nash go to town and do some practicing there as well.
My first 3 were oral sedations, no topical, and just,
Beautiful. You're a brave little girl right there, Jeanette. Geez.
Yeah.
So topical, we kind of already talked about that. It will be a provider preference. Rubber dam clamps, it gets asked sometime on the call. On the webinar, so I added it in for all you old schoolers that like your rubber dams and your rubber dam clamps. You're not giving any injections on the palatal. You can give this injection and you can put your rubber dam clamp on immediately. Bending of needles, this is probably one of the biggest things you're going to experience. So I want you to know you're in good company here. The needle is super light, tiny, flimsy, whatever you will. and they're going to bend as you're trying to get your angles right and get in through the cortical plate. You're going to have the tendency to bend needles. The best thing I can tell you is if you see the needle starting, if you see it starting to bend, not to the point of failure, reposition yourself, come back out, do something different. Don't keep just slamming and going and slamming and going. And if you bend it past the point of its effectiveness, like anesthetic's not going to get through it, or it could potentially break, put a new needle on. These needles are 27 cents, people. This isn't, we got a lot, our assistants are wasting a lot more of our money by putting too much bond around things and, throwing things out that probably could have been sterilized and reused. So don't get hung up on putting a new needle on if you need to. And then
Or once you start to see it bend because you feel resistance, lay off the pressure. You can
Right.
do a little bit of that rotational movement and it might come through. Like you don't have to
Right.
Thor
Be
hammer
patient.
it.
Right. Just be patient. Breaking needles, this is not a thing, y'all. This is just not a thing. Jordan would tell you this. They're not getting calls every week with broken needles. Let's say you broke a needle. Let's say you're the Incredible Hulk and you broke a needle. It's literally going to be hanging there in the gum and the bone, and you're going to take a hemostat and you're going to take it out and you're going to move on to the next play of the game. I am not going to talk about this very long. I put this slide in here because I keep seeing this device get brought up in some of the online social groups, especially IPEDO and some other ones. And the woodpecker is an electric dental anesthesia delivery device. It is not made for intraosseous anesthesia. That's all I'm going to say about it. So it is not comparable. It does not do the same things that these new smile tech devices do.
Along the line of that, can you address the like pediatric versus adult? Because that was the other big question that kept coming up when I posted about it last week. Like it's supposed to be for pediatric and mixed dentition currently. Is that correct? But
Jordan, you want to touch on that?
Yeah, it's really geared towards primary dentition, mixed dentition, early stages of permanent dentition, but we would not really recommend using it for like adults generally, because you'll have some success, but you might not be able to get in for all of them.
Yep, good point. This is something for us, people. Finally, something just for pediatrics. We got our own thing here. One of my favorite things, I am no longer stressed out when I have a hypoplastic 6. I know that I can get it numb with this device. So local infiltration, numbing one of these teeth about 25%, whereas if we give an IO, we got about almost a 90% chance of getting profound anesthesia. So really, really good thing for these hypoplastic molars. Normally on a hypoplastic molar, I am Jeanette. I'm getting out my septic cane. I'm giving 72 woo-woo injections all the way around it, praying to dear Jesus and his mother Mary that the patient's not going to feel something.
I'm
so
giving
again,
it
for the
an
patient,
SDF bath too.
yeah, doing all the things. So for the patient, again, what are we solving here? We're doing it comfortably. They're not going to have collateral numbness. The appointments are going to be shorter. So our patient, our timeline is going to be shorter with them. So hopefully they're not going to flip out on us in the middle of what we're doing. And then for the dentist, immediate profound anesthetic. It's going to be predictable, especially on those hypo 6s. And there's not going to be a delay between delivery and doing treatment, or you can go do whatever else you need to do in between. You're just given more opportunities. Going to reduce our stress. We're not going to have as many post-operative side effects. You're not shoving a wad of gauze in a kid's mouth when they leave unless they had an extraction. We're going to be able to be efficient and optimize these appointments. It's a great strategy that we can put in play here. And this is if you're a new doc and you're looking for a way to up your numbers and market your practice, I cannot think of a better thing to do. Because I never want to give an inferior alveolar injection again. That's probably what mine would look like to this day. That's my least favorite injection to have ever had to give. So in conclusion, we have definitely evolved. What we need is here right now. We have all these huge advantages. I hope I've convinced you of that. Jeanette said it early on that Bobby and I both explained to her that this is a game changer on so many levels. It's going to help your patients, yourself, and your business grow. This was day 1 of training. I mean, we're not dealing with like 12-year-old brave kids here. We've got little kids in the chair that we are practicing new technology on. And I encourage all of you to do that as well. Talk to New Smile about coming to your area, doing study clubs, even maybe a Zoom for you. When they were here, we had our study club get together. Dr. Prin gave a lecture, and then we all played Stab Lab and got to work on each other. Just to wrap up here, so this is a new Facebook group that New Smile Tech has put together. I encourage you, whether you don't have to have a unit to, this is not like some private special group. Please join this group. Please go find it online. I learn stuff in it every single day. People are posting their wins in here. People are posting what goes wrong in here. It's a very safe collective group of us in there talking about these devices.
Oh, and
then-
I'm gonna add in on that for that
Yeah.
Facebook group. Just make sure you answer the questions.
Oh,
to-
yeah.
that you get in. So many times that people ask, like, "Hey, I requested." It's like you just have to answer the questions,
They're
and then
the
you're
little
in.
questions,
It's
exactly.
3 questions, real quick. That's it.
So these are the people that can really help you if you want to get one of these devices in your hands, or if you're having any sort of issues with the device. The doctors are here more to support you for your technique and your strategies, but you've got Chris and you've got Jordan, who is on this call. And this is Chris right here in the middle, standing next to myself and Dr. Prin. And then at AAPD in a couple of weeks, I'm going to make Chris and Jordan take a picture with me so I can change this picture out. And then I'm just going to say a couple things here. Dr. Bobby Elliott, he brings a lot of credibility to pediatric dentistry. And these were things that he had to say about it when he got his. Hey, someone working overtime today like a boss. I took out this tooth on a 13-year-old, CNH on a 7-year-old, easy peasy. I'm pumped. The parents are blown away. Larry said, what a great job. And I just said, I love hearing stories like this. And I would put Bobby in the Jeanette category, skeptical, not the earliest adopter on certain things. And I'm just really proud of him that he jumped in and is providing this to his patients. And then Dr. Brian Richards, again, difficult to get him to spend money on stuff like this. He'd rather buy more airplanes and BS, but he got it. I just did my first sewing case. Kid broke the lower incisors, very sensitive. He couldn't even blow air on him. Gave 1 injection down there, half a septo, started right away. Kid never flinched for the beveling or the cleaning. He said he never felt a thing. It was crazy. Thanks, Dan, for selling me on this. I'll be curious how appointments go tomorrow. And the next day he posted stuff on iPedo, how he did like these pulps and crowns, and he doesn't even use nitrous. Like he's hardcore. No parents are in the back. Like he is super hardcore, and he did all this dentistry the next day. And you just got to jump in, man. That's the thing. You can't waver. You just got to jump in and use it. Last person to talk about, this is my favorite. This is Dr. Meredith Papadilla. I did it again, skeptical, was scared to get it. I numbed at 10:13. I had these 2 teeth out by 10:15. He didn't move. That's a 2-minute appointment. I said, can I please put this in my webinar tonight? We are so proud of you. She said, sure, thanks. It was a huge rush. Like, when do we get to say that in our practice anymore, right? Like, it was a huge rush. Like, yay, dentistry can be fun and new and exciting. That's what's going to keep us in the game, y'all, is stuff like this, because how many lectures and stuff is there going on out there about everybody being burned out and depressed and anxious and tired and pissed off and whatever, and things like this. It's like the light coming on. So again, here's my slide with Jeanette, because I wasn't sure what time she was going to be flying in here. She was kind enough to jump on here. She came straight from work and wasn't sure what the traffic was going to be like, but we have been friends for a really long time. We don't see each other much, but we both have the mission to move the needle in dentistry and for pediatric dentists any way that we can. And I'm just really happy that she joined me tonight on this call. And Jeanette, if you got any parting words you'd like to add,
Sure.
colleagues.
I call this picture another satisfied customer. I took video of administering to him. I hopefully will have it on YouTube tomorrow, but try to do like really close in focused pictures of all the different little steps to help because that it's so helpful. You show the videos and the pictures. That's awesome. And I wanted to share, you can, the fact that you can start working immediately, so it's shorter chair time. Like the first time I used it, the cash register started going off in my head of all the things I was saving. Like I didn't use topical, less nitrous. Nitrous is so expensive now because it's a shorter appointment, less chair time. I didn't have to switch out my gloves because I didn't go to see other patients. I stayed and got to work immediately. Because I mentioned that my initial concern is like, well, do I want to go and buy this thing? Do I need to spend the money on that? I don't think I was short-sighted and not realizing all the back end savings and increased productivity by having the shorter appointment, saving on different overhead supplies, like the nitrous and the topical and the gloves, et cetera, et cetera. And then just like add in all the extra stuff about the patient comfort being better. It really, changed my impression. And I do think it is a game changer. So thank you for guiding the way, fearless leader.
Absolutely. I'm so honored to have you on this call because you definitely light the tunnel for way more things than I do. And lastly, I'm tired. I know everybody on this call is tired, depending on what coast you're on or what you've got going on. This is my digital card. Please reach out to me. Please hit me up on social, or please follow me, or please call me, please anything. I am here to help you. Any of us that are working with New Smile Tech, we are here to help you, and we want to see you be successful. We don't want you to buy these devices and put them on a top shelf somewhere.